Greetings and welcome. My name is Juliana Boyle and I'm your host for today's webinar. Innovations in EMS Delivery Around the Country. This complimentary 90-minute webinar is presented by the Abaris Group, a consulting firm that specializes in EMS emergency department and trauma system planning, program implementation, and financial analytics. We are really glad you've joined us today. We have a large audience. Pretty much every quadrant of the country is represented. Our guest speakers for today's webinar are Bill Bullard, Senior Vice President with the Abaris Group, Dr. Eric Beck, CEO with Envision Healthcare, Matt Zavodsky, Director of Public Affairs for MedStar Mobile Healthcare in Fort Worth, and EMS Chief Jason Hockett with McKinney Fire Department outside of Dallas. We are looking forward to the presentation, but first let me quickly go over a couple of housekeeping issues. If you need technical support during the call, please call our webinar provider, GoToWebinar, at 800-263-6317 and follow the prompts for technical support while in session. With respect to content questions, please feel free to submit a question anytime during the webinar. To do that, type the question in the designated questions area in the control panel and click Send to Submit. We will answer questions at the end of the webinar over the audio system and not on the computer screen. In addition, the webinar is being recorded and will be uploaded to the Abaris Group's YouTube channel for anyone to access. Now, let me tell you briefly about our speakers today. Our first presenter is Bill Bullard. Bill is the Senior Vice President of the Abaris Group. He has a wide array of experience in an EMS, including public, private, and third-party agencies nationwide. Over the last 17 years with the Abaris Group, Bill has conducted a number of strategic EMS and hospital studies, as well as pre-hospital system reviews and ambulance requests for proposals. Our next speaker is Dr. Eric Beck. Dr. Beck is the CEO of Evolution Health and has expertise in medical leadership, mobile healthcare, integrated delivery, strategic innovation, and population health management. Prior to this appointment, he served as the Associate Medical Director and Chief Clinical Integration Officer for Evolution Health. Our next presenter is Matt Zavodsky. Matt is the Director of Public Affairs for MedStar Mobile Healthcare in Fort Worth, Texas. He has helped guide the implementation of several innovative programs with healthcare partners that have transformed MedStar into a mobile integrated healthcare provider. And our final presenter today is EMS Chief Jason Hockett of the McKinney Fire Department in McKinney, Texas. Chief Hockett oversees the Community Healthcare Paramedicine Program. The program's primary focus is meeting the needs of residents identified as frequent users of services for non-life-threatening situations. It's going to be a great webinar today. Now let's get started with the presentation. Bill, I'd like to turn the floor over to you.
Thanks, Juliana, and good morning and good afternoon to everybody across the U.S. It's great having such excellent attendance at this session. And I'd like to start us off a little more of a global look at where the industry trends and best practices are, and then we'll continue to move forward to the different speakers, and we'll be looking at from a 50,000-foot view, we'll continue down all the way to Chief Hockett, who will talk about what we're seeing at an excellent case study going on in Texas. Here's just a quick look at some of the different services that are provided across the U.S. and into Canada that are broken down into essentially 4 buckets of industry trends and best practices, and those specifically being related to how EMS is evolving and where those programs are putting into place. I'm not going to spend a lot of time on each program, but I want to give you an overview of what's going on, and maybe there's one in your area that's on here that you know about, or maybe there's one that I've missed, and I apologize if I did. There are quite a few to know about. First one I want to look at is the 911 dispatch, triage, and awareness. We've heard this Omega protocols. There are quite a few different terms for this, and the 4 programs that are currently have it in place, Richmond, Virginia on here actually discontinued theirs, But you can see that there's an opportunity for it to take a set population and run it through a little more aggressive 911 triage and come out with fewer ambulances being dispatched, finding alternatives to send those particular callers to that doesn't require the full ambulance, fire engine response, and then an emergency department visit. And the takeaway you can see here for the systems, Seattle, Houston, Toronto, is a fairly good net savings based on number of transports. What was been effective in those programs, and what Richmond cites is the reason they closed theirs down, is really focused around the complete resource access availability that they are able to offer. So not just yes or no, you don't need an ambulance, but okay, no, you don't need an ambulance, and here is a local clinic, here's an urgent care center, here is an option for you. Richmond found that its community partners, when it started the program about 9 years ago, really weren't ready to take that level of effort towards connecting in with the 911 system. The other piece we're seeing at a 911 level is we've done an incredible job of marketing 911. Whatever you need, just do it. And then we go from there. So we now need to maybe do a little education and start talking about the use them, don't abuse them, which is a program currently run in London. So he's moving along here. And then let's talk about alternate transportation destination. So what we're looking at here is mental health. How often do we end up transporting these patients into an emergency department and then they end up there for hours, which then not only clogs up the ED staff and resource dependent, but it also then limits additional beds available for the next ambulance to come in. We've got sobering centers, very similar concerns, and finally we have taxi cab voucher systems for actually getting the patients either out of the hospitals or for getting them to the hospital. Not one of the programs we typically recommend, but one we have seen implemented in a couple places in Texas. San Francisco's program for moving patients into their sobering centers is reflected in the upper graph here, and you can see that they're pushing somewhere in the neighborhood of 5,000 patients a year based on the last metrics, and they are doing a phenomenal job of decompressing the emergency department through that process. Next is high system user diversion. We like to call them EMS friendly faces. Frequent flyers is another term we often hear about. And Matt's going to speak to the Fort Worth model and what's been going on with MedStar. These are some of their early statistics of how successful they were at taking a member of the community that might be using the resource too often and pushing them in a different direction and meeting their needs before they become acute. San Diego has a program called the Resource Access Program, or RAP, and its opportunity is to connect people to the services that they're missing before it requires the use of the EMS and then pushing from there into the ED system. Primary mobile health care. Well, let's talk about this. This is one of the big things, community paramedicine. What can we do for people? Where can we do that? Is it always have to be involve an ambulance run to the hospital? No, and we're going to hear from two programs today that are specifically doing that, both in Fort Worth and McKinney, Texas. Alameda County has started to move towards a model of taking a clinic and a fire station and co-locating them. The fire departments are seen as a place to go get health care when you need it, and so they're going to co-locate them in an opportunity to connect with their communities better. And finally, I want to talk a little bit about some of the attention that we're seeing from the federal government and the CMS and Medicare, Medicaid organizers are looking at innovation awards. And here are three specific ones that are focused around EMS. Many people have heard of what's going on up in Reno. That's REMSA has an excellent program put together to offer community services. Then we also have work going on in Washington and Colorado. These programs have been going on about 3 years, which is the length of the grant. And so we're expecting to see some data come out of these programs. One of the really anticipated strengths we're hoping out of the Reno project is they actually gave back some of their money and in exchange requested the ability to charge for non-transports. So to do the assessment but not have to transport to get paid, and realizing that we are truly the gatekeepers to the healthcare system, and every transport we complete is adding to the cost of the patient care. And is there an opportunity for us not to do those but still get paid for that high-level assessment we now offer? And you can see an idea here of what some of the goals are from the different grants that are going on right now that are hoping to be achieved. And as I mentioned, that we should see results fairly soon. Here in California, where I'm located, we saw a pilot project get approved last year, and there are 10 different communities that this is happening in, and they are covering a multitude of different topics, even some more off the beaten path ones, like treatment of tuberculosis and doing follow-up care on that so it doesn't spread. And that's what's going on in Ventura County. We see some hospice support. I know that Matt's had that success in MedStar about trying to prevent hospice patients from being transported unnecessarily. And you can see the majority of the focus here is looking at other destinations for people, as well as what we can do to get patients not to be readmitted to the hospital within 30 days, which is a big driver right now on the quality metrics. Finally, I want to talk about the Beacon project. This is in San Diego. It is an excellent opportunity to show innovation. It's been going on a few years now, and essentially it is a cloud database that pre-hospital and hospitals are reporting into. Imagine a paramedic gets on scene and is able to pull up on his or her tablet the patient's hospital records from their last visit. Not only can they figure out which hospital the patients are being seen at, but they can find out what the last diagnosis was and where perhaps that patient's records are kept, and then take the patient to the most appropriate location so that the EDs don't have to do complete workups because they already have a baseline. This has a lot of promise and something that we're looking at to see where it's going to take us moving forward. With that, I'd like to turn the podium over to Dr. Beck from Evolution Health, and we're going to talk a little about what he is doing with his firm. Dr. Beck?
Thanks so much. Pleasure to be with you all today. What a very exciting time it is for EMS to be in this evolving healthcare landscape. No pun intended. It is certainly an opportunity for us all to think about a future state, thinking about healthcare as delivered by EMS systems today, as well as that healthcare for the future. And I think I just need the controls passed over to me.
You should have control, Dr. Beck. Try clicking on the slides once just to make sure your computer's highlighted those.
There we go. Thanks so much. So the idea of EMS providing a broader platform for population-based impact for integration with other components of the healthcare system dates back really to the inception of EMS as a profession, and certainly to EMS Agenda for the Future from 1996. In this document, the focus is very clearly on out-of-facility care being integrated with other healthcare system components, focusing on cost effectiveness and community-based delivery strategies. This image kind of depicts a variety of the then visioned components of what that system of care might look like in the future. Historically, EMS has been described as lying at the intersection of public safety, healthcare, and public health, and certainly that's not any more true than it is today. The tipping point around mobile integrated healthcare has come with great momentum, partly in response to changes in healthcare reform, the focus on increasing value for every healthcare dollar spent, as well as focused on the Affordable Care Act and some of the specific regulatory changes that have become a reality. Certainly in the EMS industry, mobile integrated healthcare has become a tagline, certainly synonymous with EMS innovation, and a number of exciting initiatives were just profiled for you. The 2013 article by Dr. Munjal is probably one of the first peer-reviewed scholarly articles distilling the value proposition of EMS in patient-centered out-of-hospital care delivery, and really illuminating for the broader healthcare continuum the challenges and the perverse incentives associated with traditional EMS transport, oftentimes for non-emergent conditions. The Health Affairs article, many of you have no doubt seen, from 2013, focusing on CMS-driven exploration of data, suggesting significant savings for Medicare beneficiaries, in which alternative destinations became a reimbursable reality. The American Association for Public Health took interest in systems-based thinking around the novel use of EMS as a broader lever in healthcare delivery and value-based strategies for population outcome. Crystallizing this, the industry broad stakeholder participation into the synthesis of a vision statement document. Many of you have no doubt seen. So with all that momentum, the real question is EMS ready to make the jump? That's as much a question for each of us individually as EMS professionals, as well as for the industry. I left my full-time focus in academia and EMS-based practice to come to Envision Healthcare with Evolution Health AMR, focusing on outcomes-based delivery and population impact. And really, the challenge that I'd like to bring to the discussion today is one that's been increasingly part of my reality every day, and that's to think about all healthcare as prevention, including acute care, traditional services provided by EMS, acute care, hospital care, et cetera, as part of that continuum. So primary prevention, stopping illness or injury before it happens, examples would include immunizations and weight control. Secondary prevention, stopping the progression of disease, diagnosing and treating hypertension is a good sort of classic example. And then tertiary prevention, what we're all familiar with in traditional EMS and acute care circles. These are acute illness or injury, the care that's provided to return someone to a maximum state of health. And then at the very top of that diagram is what we would call quaternary prevention. And quaternary prevention is really around a focus on mitigating and avoiding unnecessary, excessive intervention, redundant or unsafe care. And that really is where so much of the discussion today in integrated healthcare, as well as EMS-based integration, is starting to focus. So when you think about this prevention lens, all healthcare being prevention, then all of the innovation that we see coming through EMS ultimately has a touch point along that continuum, primary, secondary, tertiary, or quaternary prevention, perhaps. The focus here is obviously on the outcomes, care shifting in terms of reimbursement on the results, and certainly this is being previewed in EMS, and I think we'll dive deeper on that later in the presentation today. But outcomes, particularly for populations, becomes a key component. So when we think about the history of EMS and sort of our value proposition around innovative offerings, populations and outcomes, and specifically the cost the cost containment side, systems of care become a great example. So STEMI, stroke, and trauma have provided remarkable improvement in outcomes, efficiency, and are a hallmark of traditional EMS system design. Pre-hospital non-invasive positive pressure ventilation, so CPAP, for example, has such a tremendous impact in terms of cost savings down term and helping patients who would have historically, prior to CPAP in a pre-hospital setting, have been intubated, foregoing the intubation, turning their clinical trajectory in a more favorable direction, has both clinical patient experience and cost outcomes. The concept, as you heard, around PSAP, nurse triage, alternative destination care navigation, fantastic example. Syndromic surveillance, Ebola being one of the most recent examples, and then primary prevention, things like the numerous injury prevention initiatives that go on EMS systems and fire agencies across the country. If we think about where the greatest opportunity may lie in front of us today for EMS and for all of healthcare, you really start to think about the existing waste in U.S. healthcare systems. This comes back to that quaternary prevention bucket. And here what we see is that total waste, as captured by this slide from Johns Hopkins, was tagged at $1.2 trillion, with $25 billion of that coming from preventable hospital readmissions and $14 billion coming from unnecessary emergency department visits. Certainly lots of opportunity for EMS to potentially intervene and add value in any one of the buckets displayed on this particular slide, but just as examples and so much focus on EMS innovation around alternative destination, care navigation, and readmission prevention initiatives. At Evolution Health, we've sort of fully embraced this future, and our clinical strategy focuses on leveraging existing clinicians, their existing scope of practice, building an interprofessional team to deliver care and play the game in a way that historically they haven't been connected to deliver care. Patient-centered and population-oriented teams are really a cornerstone of much of the discussion today around how healthcare agencies position themselves to remain relevant in the future. And this is as true as for a dedicated EMS agency as it is for a multi-service public agency, a fire department, etc. The unifying lens, of course, is focused around the triple aim. Population health, experience care, per capita cost. So again, outcomes at a clinical and population level impact, experience of care, and then the economical side of the analysis. Value is really about cost and quality, and the real question for our dialogue today is how do we architect mobile integrated healthcare programs, innovative EMS offerings that deliver on both improved cost and quality as we move forward. A good place to start is thinking about the definition of quality. The Institute of Medicine talks about the degree to which health services are impacting populations and the interventions and outcomes being consistent with current professional knowledge. So that's essentially the evidence-based interventions that can be delivered to improve population-level outcomes. There are dimensions associated with that quality: safe care, effective care, patient-centered care, timely care, care that's equitable, and obviously efficient. So when we think about where EMS is headed, when we think about the opportunities that are in front of us today, when we think about that clinical strategy that positions us to remain relevant, when we think about an outcomes-based future, these are the dimensions by which our future will be judged. EMS has certainly embarked on this, a number of strategies around measurement, evidence-based performance measures, a classic paper from PEC by Dr. Myers et al. Around thinking about our traditional opportunities for impact with ST segment elevation MI, seizure, pulmonary edema, trauma, cardiac arrest, and the organization of these around structure, process, and outcome impact. And that's really important. So when we think about structure, this is the components of the system that have to be there from a foundational standpoint. When we think about process, these are the activities that are provided by the system that ultimately influence the outcomes, which is what we all care about at the end of the day. The concept that you can't actually engineer an outcome, but you can do things that help influence an outcome or help move a population towards an outcome is a key component. So traditionally, when we think about this, inputs into a system, the structure components. Do you have a medical director? Do you have protocols? Do you have a dispatch center? And then the activities that those things deliver collectively can then equate to outcomes at a population level. And think about STEMI, stroke, or trauma as examples of that. As we start to focus more on the future, it may behoove us to kind of flip the script a little bit and start by saying, what is the target population we're trying to impact? What are the needs associated with that particular population? That frames the outcomes of interest. And then the activities that are required to influence those outcomes become pretty readily available. And then what inputs or structural pieces are required to be able to conduct those activities, those processes that will deliver on the outcome. So this population-oriented sequence, where you start with a population, you identify and define their needs, those outcomes then feed specific, allow you to define specific processes to influence and deliver on those outcomes. And then the foundational or structural elements that may take into account nuances of EMS system, capabilities, funding sources, regulatory constraint, et cetera. So that all being said, EMS, despite being one of the most innovative and nimble healthcare professions, is still relatively young and is by many measures a minority in the total healthcare delivery workforce picture. Here depicted as the purple, you can see clearly a minority when looked at in the entire scope. And so that point I raise merely to suggest that we all want to start to think about how we integrate, partner with the broader healthcare landscape. It's going to take strategies that link all of those healthcare professionals together. As we start to think about what that means for our future, what our innovation journey looks like, a big chunk of that is making sure that we're linked with the strategies and the approaches that the rest of healthcare and the rest of those healthcare professionals are thinking about. The Institute of Medicine has described core competencies for all healthcare professionals. And as EMS increasingly moves into population delivery, integrated healthcare strategies, helping to position EMS to deliver on maximal value for their healthcare system and their communities, these competencies become increasingly relevant and perhaps even more relevant than the traditional EMS and public safety sort of focus within our preparation. So patient-centered care, working in teams, employing evidence-based practices, quality improvement as a focus, and then obviously IT, the ability to measure and leverage that information to intelligently inform program design. Team-based care is obviously a core component of that, and part of our journey at Envision Healthcare Evolution AMR has been around embracing and understanding interprofessional collaborative practice models. There is not a medical school, a nursing school, a pharmacy school, a public health school, a dentistry school in the United States that isn't increasingly positioning their workforce to be part of an interprofessional team. And interprofessional is distinguished from interdisciplinary or multidisciplinary in that these are actually different professions. So within medicine, cardiology, emergency medicine, family practice are all different specialties, different disciplines within medicine. An interprofessional example would be medicine, nursing, EMS, et cetera. And so just as we're seeing an emergence of a community community-oriented discipline, a community-integrated discipline within EMS, we also want to think about that broader interprofessional strategy. Unique to that is each profession having unique knowledge and competency to that particular profession. Certainly lots of things are shared amongst all types of professionals that may be part of the team. And then the competencies around how that team comes together to deliver care as a team. And so, one example is lots of clinicians can take blood pressure. Only some clinicians can perform intubation, for example. And how you link together clinicians who have those different skill sets into a team that is able to deliver on an outcome becomes a really important strategy for the future. And our education and training, thinking about that community and population orientation, is going to be essential for how EMS moves into the next phase of our journey. Challenges and opportunities are really what innovation is about. Performance and funding today are not aligned towards value, although I think you'll hear today that that's shifting significantly. The evidence base, as we saw, is present for some interventions and lacking for others, and that's an opportunity as much as it is a challenge. There is an incredible value proposition for our upstream position in the care continuum that can influence cost downstream. A focus on team-based and interprofessional strategies, some really exciting things coming from around the country. The embedded nurse practitioner model, for example, advanced practice nurses and physician assistants working directly with fire departments is a fascinating example. Certainly some of the exciting work that was profiled in the intro segment exemplifies those types of partnerships and collaborations as well. The young and motivated workforce that we have in our roots in innovation in terms of founding an entire delivery system for time-sensitive and critical conditions. And whenever we have antiquated reimbursement models or regulatory models, they become very ripe for disruption. So as we think about today and we think about the future, I would suggest EMS has deep and unique competencies in population health, perhaps more so than any other segment in the healthcare delivery system. We have always been set up to care for populations, whether geographically defined, whether defined by disease states such as STEMI, stroke, or trauma. EMS is well positioned to create or destroy value in the care of populations. So as other members of the healthcare delivery system try to influence outcomes and costs, being sure EMS is part of those discussions and strategies, and more importantly, the delivery arm is significant. And we're obviously very early in the journey, so these challenges and opportunities continue to be part of the future. Thank you. I'll go ahead and pass the controls over.
And as we have an uncomfortable pause, okay, well, good. I guess I'll pick right up. Hey, everybody. This is Matt Zavatsky coming from the Republic of Texas. Just want to make sure with my presentation that people can hear me okay, so I'm going to wait for one of my team members or have one of my team members make sure that they can communicate that well and that you can hear me okay. I want to share with you a little bit about what's happening as it relates to the metrics and how we're measuring the performance. You heard Dr. Beck and Bill certainly in many cases talk about the value proposition and how do we demonstrate value. And this is kind of interesting from a mobile integrated healthcare perspective because it is such a new delivery model that we really need to find some metrics to help evaluate that. And then the second part of the conversation will be around what's next in this evolution, or some might say revolution, in EMS into mobile integrated healthcare, and talk a little bit about accreditation. And I know that makes people really nervous to talk about accrediting something that we maybe not have even defined yet, but perhaps this process in some cases may actually help us define that. Before starting, I also want to mention that in Bill and Dr. Beck's discussions, they talked about how these programs are evolving. Bill talked about the 3 Healthcare Innovation Awards that have already started or are actually winding down at this point. There are also, for some of you who don't know, in round 2 of the Healthcare Innovation Awards through the CMMI, 3 more EMS-based or EMS components of awards that have been given out to the tune of almost $20 million amongst 3 of them, one in Mesa, Arizona with Mesa Fire Department and the program that many of you may know about going on in Mesa. The Icahn School of Medicine, Dr. Munjal and his team at Mount Sinai also got a CMS Innovation Grant for a community-based care program that includes community paramedicine. And Yale New Haven Hospital in my home state of Connecticut, also Jimmy Baturis and his team got one also that's a community-based healthcare innovation award. So this has clearly gotten, this model has gotten CMS's attention, other payers' attention. So being able to measure the outcome of these programs is going to be hugely important in order to prove their value and to change payment policy, as you've heard so far in this webinar. Medicare has done a great job developing outcome metrics and performance-based metrics for virtually every aspect of healthcare delivery. They publish on their website Hospital Compare, Nursing Home Compare, all the compares that you see on the screen, but there is one that's notably missing so far, and that is EMS Compare. And trust me, and many of us who have been working on this for quite some time truly believe that value-based purchasing, payment based on outcomes, payment based on quality, is coming to EMS. And we are in a unique position, as Dr. Beck indicated earlier, to maybe perhaps help drive the quality metrics that will be used for traditional EMS, but certainly mobile integrated healthcare as well. So as it relates to measuring the outcomes for MIH and CP, the genesis of this project sort of began about a year ago, almost a year ago exactly, when Brenda Staffen, myself, Dr. Myers, Dan Swayze from Pittsburgh, a few others met with Dr. Patrick Conway, who is the Chief Medical Officer for CMS. And one of the insights that he shared with us is that these programs on the surface and you know, on the very surface look good, but we need to drill down into some really good outcome measures. We really need to have a uniform reporting process so that as agencies in California and agencies in Colorado and agencies in Texas or anywhere else are reporting outcomes, the outcomes that they're reporting are consistent and they're being calculated in a consistent way so that we can identify opportunities, exalt huge wins, and really, quite frankly, then change payment policy. Because with the smaller populations, it's harder to do, but if we had larger populations that were being impacted that actually had good uniform outcome measures, it's easier to change payment policy in that regard. So with that council, Dan Swayze, Brenda Staffen, and I started and then invited Brian and Gary and Brent into the process as well to begin to look at outcome measures for mobile integrated healthcare. We also reached out to numerous stakeholder groups, certainly those folks that were operating MIH and CP programs, but also the stakeholder associations that are key to helping influence payment policy as we move down the road. So ACEP, all the alphabet soup that you can imagine, from an association perspective, have been invited and are now participating. But more exciting is that we've reached out to a couple of the key external regulatory or research partners to help us with this process as well, and that is AHRQ, as well as IHI and NCOA, the folks that can help us with good measures, with national quality forms, statistics, and the things that go along with that. So we're very excited about having those people as part of the process as well. And in fact, we just had a webinar conference call 2 Fridays ago, and all of these folks, we had over 50 people working with us on this process. So what does it mean? What does it look like? So here's what we've done is we've drafted, and we cannot emphasize enough the draft term here, that there are a number of different program measures and outcome measures that we've put together. The first was, and we heard this from CMS, is that there needs to be some program structure or program design measures. How do we assure program integrity? How do we not have this be as subject to fraud and abuse as, let's say, well, ambulance transport? Because every time you talk to somebody inside the Beltway or somebody at CMS or a contractor for CMS, all everybody wants to talk about when it comes to ambulance service is all the fraud and abuse in the ambulance industry. Well, how do we assure that MIHCP it has some program integrity? So we spent a lot of time on the program integrity. We spent a lot of time on the outcome measures for community paramedic programs, because that was the most common, or the most common MIH program that was going on out there. But we do know that there are other types of programs, as was mentioned earlier, like 911 nurse triage, alternate transportation destinations, and we're going to be building measures and outcome metrics for that as well. So notice that we also have the quality of care metrics and then also utilization metrics. So the cost of the care and the utilization, how are we measuring how these things are going to be reported, incorporated in many of the CMS Big Four measures and others that have really focused on total cost of care, for example, as one of the main drivers of whether or not these things are helping achieve that third leg of the triple aim, which is reduced per capita cost. This is an example in the document of what a structure program design measure looks like. These are a little bit different than some of the outcome measures that we'll show you here in just a moment, but notice that one of the core measures at this juncture is the fact that these people providing this care, whether they be paramedics, EMTs, others, have to have some type of specialized training. And as a testament to the interactive and evolutionary process of this document, this S10 measure was one that we hadn't had on the radar screen for the first 8 months that we were developing this, until we had some face-to-face meetings with stakeholders in different parts of the country and during the EMS Today conference in Baltimore in February during a workshop. Somebody said, shouldn't we have like some training metrics as part of the program structure? And we all kind of looked at each other and said, duh, you definitely need to have that, so we added that in. So this is an example. This would be a core program measure, and you have to be able to demonstrate that the people providing this program have had some type of specialized training in order to know what it is that they need to do for the folks in your local community that you're enrolling in these programs. And you'll notice, I want to go back to that one for a second. Notice that this was relatively subjective. So the scoring for this, if someone is going to be submitting this as a metric, is that they're able to demonstrate and submit proof, documentation, whatever it is, that there is a specialized education offered, or there's a specialized education offered and it meets or exceeds some nationally recognized or approved state curriculums, such as an overall scoring mechanism that would be used for some of these program structure design measures that will help prove some program integrity. Moving on to an example of the utilization metrics, because this is a biggie, as Dr. Beck and others have talked about in this webinar and many people have read, being able to prove change in utilization, change in cost is a huge component here. So notice that when it comes down to something as simple as utilization metric number 1, which is ambulance transports, the goal of this measure, or the goal of the program, would be to reduce the rate of unplanned ambulance transports. And notice here that unplanned ambulance transports is actually highlighted and underlined in the electronic version of this document. Everywhere that we have that highlight and that underscore, there's a definition included at the end of this document for what unplanned ambulance transports really means, making sure that that is a uniform definition that everybody will be utilizing. We even define the term enrollment. What does an enrollment mean into the program? But you can see we get relatively specific into how these metrics are going to be calculated. If you're going to say we've reduced ambulance transports and you want to quote a number, this is how you calculate the number. So that way, if Dr. Beck is reporting this outcome in St. Louis, Missouri, we're reporting this outcome in Fort Worth, or Dr. Hockett is reporting it in McKinney, it's being reported, measured the same way so that we can actually show that it's uniform across the country, it's scalable, replicable, all the things that CMS wants to see with those types of programs. So we spent a pretty significant amount of time on coming up with how do you calculate the values for these metrics so that we can be universal and certainly uniform across the industry. Just want to mention one or two things before we go into the accreditation. This is a work in process. Many of you on this webinar may actually be on this team of 50 people now that are working through this process. We've developed a core group of 17 measures that we believe everybody has told us they could report, should report, and are valuable. We've done it for program structure and the community paramedic intervention. We have now work groups that are working on similar measures for the 911 nurse triage component, the ambulance transport alternative component, and process measures for the community paramedic program. You'll notice that all of these are essentially outcome-based measures, but we do know that many people are interested in process measures. How long does it take to get someone through training? How long does it take from the time someone's referred into the program to you make first patient contact to enroll that patient? How many referred patients actually end up being enrolled? All those different sort of process measures, there's a whole team of folks working on that as well. But we felt early on outcome was the big deal. It's what the healthcare system is looking for. It's what the payers are looking for. So we focus primarily on the outcome metrics for the community paramedic and for the program structures and are working on the outcome measures for the other interventions of 911 nurse triage and ambulance transport alternatives as well. Second thing we want to talk about is accreditation. So yes, we are the first ones to admit these programs are in their incubation phase. They are in their infancy. They are slowly evolving. I think the most experienced programs, if we want to go all the way back to Red River, if that program we're still operating, but there are some programs like Wake County, Eagle County, Colorado, ourselves, that have been doing this for 4 or 5 years or longer. And it's probably time to start talking about what is some standardization, what is some accreditation. So we began to think, as we talk with payers, as we talk with healthcare system stakeholders, if we really want to be serious about this, then we need some type of an accreditation standard. We have accreditations for fire agencies. We have accreditation for police agencies. We have accreditation programs for ambulance companies or ambulance services through CAS. But none of those really fit the model of mobile integrated healthcare. And reaching out to healthcare stakeholders, we wanted to see if there was a partner that was willing to work with us on developing some standards that might, emphasis on might, be used for accreditation. So we did actually reach out to NCQA, National Committee on Quality Assurance. And one of the reasons we reached out to NCQA early is that almost all the payers have to be accredited by NCQA. Many disease management programs, home health agencies, disease management providers, case management providers are all accredited by NCQA, and we wanted to maybe reach out and seek accreditation from the same organization that they're familiar with. So when you're sitting across the table with an Aetna, a Cigna, a Blue Cross Blue Shield, and you talk about NCQA accreditation, that means something to them. It might not mean something to them when you tell them that you're CAS accredited, because you have to explain what CAS was. So no offense to CAS, they do a great job, but we really wanted to reach out for the healthcare type of accreditation process. So this is a little bit about NCQA. Trish Barrett is the Vice President for Product Design and Support. We met with her a year ago in Washington, D.C. at their offices and said, we should probably start talking about this. They agree that some of their models, actually all of their models, might not fit EMS-based mobile integrated healthcare, but she was willing to work and her team willing to work with us on that process to see if there's a model that they can develop or that others can develop that can be an accreditation standard for MIHCP services and perhaps even 911 nurse triage, just so that we have some aspiration to achieving that gold ring, if you will, for these programs. So what we are doing now at MedStar is we're actually going through the disease management accreditation process for our mobile integrated healthcare program. We started this process back in September, and it has been an arduous process, but a very worthwhile process. Any of you on the webinar who have been through an accreditation process knows how valuable the process is, because it teaches you a lot about things that you need to formalize or things that you need to have metrics for or things that are important for external stakeholders. And this just gives you an example, a snippet from one of their publications about the disease management program. It talks about evidence-based programs, that your program needs to be evidence-based. And how does that work? And here are the definitions of evidence-based. So for an EMS-based MIH program, what is your evidence base? Have you gone back to heart association standards? Have you gone to other disease management standards, care management standards that are evidence-based to develop your program? Care coordination was the other one that happened to be on the other side of this column. But how do you document and prove that you're doing care coordination with other stakeholders, with the patient, all the things that are important to have a true quality program and one that can be accredited by an organization such as NCQA. When you drill down into it a little bit further, here is one about patient experience. Now, many of us have been waving the banner of patient experience metrics for a long time in EMS, but yet it's something that many EMS providers haven't tracked well, let alone MIH providers. So we had to make sure that we had a robust set of data metrics relevant to the patient experience. So notice there that we need to have at least a year's worth of data and preferably 2 years worth of data showing patient experience, that we're tracking it, that we're acting on the patient experience data that we get. And again, this is just one example of the scoring metrics for what are arguably 30 to 40 different measures that we are going to be held accountable for on our NCQA site visit, and they're doing their site visit in July. So we have to make sure that we can demonstrate all these things that we're doing that are consistent with the standards for NCQA. Cost reporting and efficiency, here's another example. So this just shows you the level of detail. Again, anybody who's been through an accreditation process knows how difficult this can be, but how important it is for you to be able to improve your process, have a process improvement plan, and be able to document well your outcomes, your costs, your patient's experience, all the things that relate to an accreditation program or an accreditation process. So with that, I'm going to turn the floor over to Chief Hockett and the folks. I see the mouse moving without me touching it, so that must mean that someone else is in control, and we can pass the gavel. Jason, you're on.
Thank you, Matt. Good afternoon, everybody. I'm going to speak to you a little bit today about our community health paramedicine program in McKinney, and not specifically about our program, but more focusing on why the fire-based side of it, some of the challenges that we've had, how we've overcome them, and the implementation of our program, then how we got some buy-in from our people, and then some results. So this began with our medical director, Dr. Elizabeth Fagan, through Best EMS. She is with Baylor Hospital, and she helped us to prove that fire-based community paramedic program improves health while reducing cost. She was a vital part to our program, like I say, not only developing it, but continuing it. So a little bit about McKinney. We're about 30 miles north of Dallas, population 150,000. We have 8 fire stations. We run 5 ALS med units. We run 7,500 calls, EMS calls per year, which represents about 75% of our total emergency calls. We're staffed by 151 certified firefighter paramedics, then 9 advanced practice paramedics that we had trained that we'll talk about a little bit later, and then some of our other specialized training as well. So we got into this, and we said, why CHP? And this was an easy thing to see. Miss V called 911 59 times in 1 year. Mr. T readmitted with COPD 3 times in 2 months. Ms. P had 14 911 calls, 11 ED visits, and 6 hospital admissions in 5 months. And then Mr. K readmitted for CHF 5 times in 5 months. So we look at this and we try to determine, why is this happening? So the initial state is the patient feels sick. They call 911. We transport them to the hospital because that's what we do. The ED either admits them into the hospital or stabilizes and discharges them. Then the patient returns home without access to follow up to a PC through their doctor or medications. The patient feels sick again, calls 911. So this is a vicious cycle that we're all very familiar with, and the ED ends up becoming the patient's PCP. So why fire-based? We looked at this, and we already, especially in Ms. V's case, we've dealt with her 59 times in the last year, so we've seen her more than once a week. We have, to say we have knowledge of her is an understatement, and we possibly already have that relationship, that connection with her. We have a trust factor in our community already. It's proven fact. They'll let a firefighter in their house sooner than they will anyone, so we can develop those relationships a little bit quicker. We can reduce 911 calls and keep medic units available for the high acuity calls, and then we already have a relationship with the local hospitals that really came into to play later on as we started taking referrals from them. So some of the challenges that we had when we were trying to start our program, we're competing for the same budget dollars. And what I mean by that is we have a firefighter association that their #1 priority may be 4-person staffing, which makes total sense. And when we then in turn want to start a program, it takes away from that. So that was a challenge that we had to overcome. And then change isn't easy in the fire service. We want to continue doing things the way we've always done them, and because if it's not broke, we don't want to change it. And then reactive versus proactive. The fire service in general is a reactive force. The house catches on fire, we go out there, we put it out. This changed in the 70s with America Burning, and we introduced fire prevention. That was a proactive part and has been very effective. So EMS is also a reactive part. Someone has a heart attack, we go out, treat them, and transport them to the hospital. And CHP is now the proactive part of EMS, and it too will be very effective and has already shown to be. And then the last challenge was education. Matt mentioned earlier about the education with CHP and the need for more. And we're going to talk about that a little bit more shortly. So our implementation, it started with our fire chief with a vision, and he started laying the groundwork. He continued to, he got some pushback, and he continued to lay that groundwork. And we found a core group of paramedics that were interested in patient outcomes and patient care. And we took these guys and explained to them the vision. They bought into this. We then went to the Gathering of Eagles conference, which I know y'all are very familiar with. And they were talking about this new concept in EMS about community health care. These guys bought into this 100%, and we then decided to start a six-month pilot program with 2 firefighter paramedics on days. The focus of this pilot program was the high utilizer group, and we were also taking referrals from the field from our med units. In order to do this, we addressed the education first. We had to do this because, again, as paramedics, we know how to assess patients, identify the life threats, treat them, take them to the most appropriate facility, but that's where it stops. Our pathophysiology of diseases is very low, and therefore, if we are going to explain to a patient about their disease process, or we are going to bridge the gap between the patient and their doctor, we have got to be educated to that level of their disease processes so that we can effectively communicate with both. So we worked with Dr. Sharon Malone, that's the Associate Medical Director at Collin College, and she developed a curriculum for this. And it was a 9-week class that proved to be very effective. So we started our pilot program. We started seeing patients, and if I can get this to change. So our results of our pilot program, we had some big wins. Patient outcomes improved. The medics that are seeing the patient see the progress. Their morale goes up. They see a 63% reduction in 911 calls. So they start to get buy-in from the field where there was resistance before. They're starting to see buy-in. They see the results from their referrals, and they're not going out to Miss V's house very much anymore, and they're noticing that, and they start seeing the value in this. There's a 66% reduction in ED visits, a 67% reduction in admissions, so the hospital starts seeing the benefit to our program as well. So our program begins to gain a lot of momentum. the City Council hears from citizens in the program and the big wins that we're having with them, and they are obviously on board as well. So because of this momentum, our program is able to expand. We changed from 2 firefighters on days to 2 firefighter paramedics on shift 24/7. We increase our minimum staffing by 2, which always helps the firefighter association. They will buy into increasing staffing every time. We now have a 24-hour hotline, so our squad gets to go out, and if Miss V happens to fall but is not injured, she can call the 24-hour hotline. Our CHP guys go out, they can pick her up, and not only does that keep a med unit and an engine from having to go out there from a 911 call, it also gives them the opportunity to see if they can prevent the fall in the future. So there's 2 benefits to that. So they start taking referrals from the hospitals at this point. We're able to expand because of the added people. And our main focus at this point with taking referrals from the hospitals is CHF and diabetes. We now respond to medical emergencies 24 hours a day in place of engines. They also start seeing the value in that, and the city is seeing a savings as well. And then finally, the squad gets to respond to structure fires for manpower. They're still firefighters. They still are wanting to go to fires, and they can not only get to do that, but also they can be assigned to rehab if needed. So we're taking care of our citizens, and now we can even help to take care of our own. So I've got one patient that I want to go over quickly. It's just one example of what we have been able to do in this program. We take pilot patient number 1. He's got 8 911 calls and 5 hospital admissions in 180 days. They enroll him in the program, and they start trying to figure out what's going on with him. Why is this vicious cycle happening? They find out that he's got 3 small children. He has to choose between feeding his children and buying his medication, so he's feeding his children. So the first thing that we do is work with Meals on Wheels, and we take that issue away for him. Now his family is getting fed. Now he can afford his medications. He can't get to the doctor's office because public transportation won't let him ride without one of his children in a car seat. So we work with an organization, get him a car seat. Now he's able to go to his primary care physician. We also get him enrolled in Medicaid, which not only helps him with his doctor bills, but as we'll see in a minute, they actually retroactively paid some of his bills. So the results for him were 2 911 calls and 1 transport, which one of those 911 calls was from, instead of COPD, and that was his issue, by the way, was COPD. And one of his 911 calls afterwards was because of an assault, so it had nothing to do with his COPD. Then the one hospitalization was while they were trying to get his medication straightened out. So obviously he had a lot better quality of life, and that's hard to put a price on. So as far as EMS cost, he had built up a bill of $8,000 with EMS. It was projected a $16,000 bill if CHP was not involved, and his actual cost was $800, the 180 days prior, or after, excuse me. So his hospital bills, he had a bill of over $95,000 because of his hospital admissions in the 180 days prior. Medicaid went back, and I believe they paid $20,000 of that bill. And then post-enrollment, the 180 days afterwards, his bills were just over $11,000. So from this, is it working in McKinney? Absolutely it is. Ms. V called 9 times in 12 months rather than the 59 times prior to that. Mr. T readmitted with COPD 1 time in 6 months instead of the 3 times in 2 months. And then Ms. P, instead of all the 911 calls, ED visits, and hospital admissions, she had 1 911 call and no ED visits, no admits in the 6 months after. Then Mr. K readmitted for CHF 1 time in 6 months as opposed to the 5 times in 5 months previous to that. So the next thing that we were hoping is that we could recreate the results that we had in the 6 months, in the 6-month pilot. So in the first year, our results came in, and sure enough, we were able to reproduce them. We had a significant reduction in 911 calls, ED visits, and hospital admissions. Our 911 calls 6 months before averaged 7.07, 6 months after 2.14. Our ED visits were the 6 months before were 8.64, the 6 months after 1.89. And then hospital admissions went down from 3.1 to 0.75. So we were able to reproduce those results. And we continue to produce good results, and our program continues to evolve as the needs of our citizens change. So I guess at this point I will pass it back to Juliana.
Thank you so much. What a great presentation all the way around. I would like to ask Bill if you'd like to handle the questions at this point.
Great. Thanks, everybody, and appreciate everybody staying on task and on time. So we do have some time for some questions. And let's start off with just one thing that I know has been going on with the JAMA editorial board. Matt, do you want to speak to that?
Sure. For those of you that are still hanging with us on this webinar, the concept of mobile integrated healthcare and community paramedicine has gotten the attention of a number of very important and influential healthcare system leaders. Many of you may know that the current president and CEO of the IHI, Maureen Bisignano, wrote the foreword to the Mobile Integrated Healthcare and Approach to Implementation book, so that's clearly on their screen. But also wanted to make you aware of, in March, a group of folks led by Donald Berwick, who was the former president and CEO of the IHI and helped lead the development of the Triple Aim, went on to become the CMS administrator in Washington, and is now doing a number of healthcare leadership roles. He and a number of folks have gotten together and created the Healthcare Leadership Alliance to help push even further the Triple Aim implementation. They've got payers, they've got large health systems as part of that leadership alliance, and again, it's led by Donald Berwick. But in their press release, in their announcement of this Healthcare Leadership Alliance, which was published in JAMA March 26th of this year, just the last few weeks, one of the things that they mention, and by name in their editorial, in their press release, is the use of community paramedics to help achieve the Triple Aim. So when we've gotten, and I think Dr. Beck very appropriately talked about the tipping point, when you've got folks like Donald Berwick and the CEO of the Cleveland Clinic and a number of folks like that who are including the term community paramedic and community paramedics in their press release, and we'll get that out to the attendees and to the editorial that was in JAMA, so you can actually have it to carry around with you and reference when you're talking to folks in your local community. I think it's pretty clear that we've reached the tipping point. We just have to make sure that we can keep the flame alive and move this towards sustainability long term. So I just wanted to bring that up because that was a groundbreaking moment when we saw that term used in that level of a industry announcement. Thanks, Bill.
Thanks, Matt. And I should also have clarified during my presentation, the community paramedic projects within California, the pilot was approved last year. The sites have done the initial general training for the community medics, and they are moving into the site-specific training for the different areas we were talking about, and expect to see that becoming a live program hopefully later in 2015. And it'll be a 2-year pilot is the approach. And just a reminder that you can post your questions through the GoToWebinar app on the right side of your screen, and that's how we're going to be taking questions and pushing them back to the speakers. And I'd like to start off with Hugh, who asked Chief Hockett, you mentioned several barriers to starting your innovative programs. Some have suggested that fragmentation within EMS is also a barrier. Do you encounter this as a barrier, and how might we address this obstacle in the future of EMS?
The fragmentation?
Correct. So what are some of the barriers?
The barriers as far as our program, most of our barriers were internal barriers, and as far as getting our own people on board, as far as the external, the developing the relationships with the hospitals and the doctors, and that was, I would say, the easy part. It was time consuming, but that was the easy part and probably the most important as well.
And I think he's looking at fire versus healthcare. He posted a versus commercial versus volunteer, all the fragmentation of the system within EMS.
I don't guess I understand your question. The as far as Firebase doing it is, I mean, that's all. I guess we're all one system as far as in our city. I mean, we're doing the transport, we're doing so it makes sense for us for the fire department to be doing the community health, because we're the ones involved with them already. I don't guess I understood your question originally.
Hey, Bill, can I take a stab at that for you?
Sure,
please
absolutely.
do, Matt. Please do.
Sure. It doesn't matter, and many of us on the webinar and folks that have been talking about this for a while, the fragmentation of our system has killed us, has literally killed us for 30 years. And we need to coalesce around a mission of essentially meeting the triple aim. How do we, as various providers, whether you have a Star of Life, a Maltese Cross, whatever your public-private, third service, municipal, whatever it is, if we put the patient first, if we put doing the right thing for the industry, doing the right thing for the patient, we can find a way to get together and come up with some common nomenclature, to come up with some common delivery models that make sense. Is the private sector the ideal place? No. Is the fire department the ideal place? No. It depends on the local community, and it requires collaboration. This game is won at the field level, at the community level. So what Jason and his team were able to do, what we've been able to do, what the folks in California are doing, or Colorado or Wake County, is they've partnered, and they've bridged those gaps. They've gotten over themselves in many respects to partner with the folks in their community and say, hey, we want to partner to focus on making the patient's outcome better. So I think to the extent that we can, in response to the question, we have to eliminate the fragmentation. The healthcare system has been forced by payment policy to stop operating in tubes of excellence, what we've formerly referred to as silos, to do good care transition, to do good care across the continuum. So it doesn't matter if you're in Evolution Health or you're ABC Ambulance Service in Massachusetts, working together to find a way to meet the patient's needs and meet the needs of the system is going to be the key to the future. If we keep maintaining this fragmented approach to things, whether it's in DC or the state capital or elsewhere, we're just shooting ourselves in the foot.
Dr. Beck, anything that you'd like to add as well, looking at the fact that Hugh also comments that there's currently many in EMS are resistant to being in healthcare and maybe see themselves as a more classic role as maybe public safety, and can we overcome that?
Yeah, happy to comment. So, you know, my career began as a paramedic. I had the privilege of working with a large fire-based system in Chicago, and now I'm working on in a private sector, and said partnership makes a lot of sense, and in fact it becomes very easy.
I think, Dr. Beck, we're losing you there, so I'll come back to you in a minute. We'll just make sure we've got your connection solid. There's a question also asked by Jean that says, how close are we getting payers to recognize community paramedics, and will we see a funding stream in the next 5 years? And I know, Matt, you've had some success at identifying paying sources. I'd love to start with you, and then if we could move around, that'd be great.
Sure, I'll be real brief. Find value, demonstrate value. So when we started our programs in 09 and 10, we did it as a demonstration project. We self-funded it. We were able to prove by asking the potential payers, what data do you need to see to prove success? We were able to produce that data that proved success, and then they were willing to write checks. The first 300 patients that we took into our program had no payer source. Today, every single patient that's enrolled into any one of our 7 programs comes with a payer source. So every patient that's in the program is getting paid, even the ones that go to the nurse in the nurse triage center through the 911 center. Every time we do that service, we're getting paid for it. It takes time, it takes effort, it takes determining who's financially at risk for those patients, and then demonstrating the value that you can bring. Now, Medicare is a whole other discussion. They may or may not at some point be a funder for this program. They may give us a billing code, they may not. If we hang our hat on Medicare changing payment policy to pay for community paramedicine and mobile health care, I think that we're all going to be retired and living in the Cayman Islands by then. But there are other payers and people who are at risk for the financial outcomes of these patients who are writing checks today to make these programs sustainable. Find out who those are in your local community, and you can, with the right messaging, the right outcomes, the right program, find funding to keep it a pretty significant revenue stream. We've gone from $0 for this program during the demonstration project to $1.4, $1.5 million revenue stream annually on a $38 million budget. It can be done.
What we have experienced in McKinney, I guess, is kind of like Matt's program did in the beginning. I think there's money out there for pilot programs, and you missed that window. Where we're at right now is pretty common. They want 2 years of data to prove that your program is sustainable, and we are supporting our own program with the exception of an iStat in the cartridges, some things such as that. But we are reaching that point in June, so hopefully that will change for us as well as we are able to get that data, and hopefully we will do better with funding after that.
Great. Thanks, Jason. And Dr. Beck, do we have you back on yet?
Yeah, sorry about that. I would agree with Matt's comment. I think value is the common denominator. I think that there are some challenges that go beyond sort of traditional EMS defined geographies that make this challenging. Many of the financially at-risk entities, whether it be a payer or ECO, et cetera, their patients, their membership, et cetera, extend well beyond a single sort of EMS system's reach. And so looking for approaches that help to standardize and bridge uniform measurement strategies become really important when you think about how to meet the needs of their population as opposed to the individual patient. But I do think value is the right denominator. Certainly tremendous opportunity and significant traction with health plans and health systems that have financial responsibility.
Perfect. And let's come back to Monica's question that when we lost you about the variability between states and licensure, training, et cetera, and even the scope of practice for EMS. And how will there be a standardized evidence-based performance measure or a quality control assessment?
So, you know, at Envision Healthcare AMR Evolution, you know, we've really focused on unifying strategies. So, rather than trying to develop independent measures of performance, of quality, we're using the measures that are already being used by the rest of the healthcare system. So, there are ACO quality measures, there are health plan HEDIS measures, there are a variety of metrics that make sense. The question becomes, how do you solve for the right processes, the right activities to influence those outcomes, and then the structure, what's the right system, what's the right team to be able to deliver that care, EMS obviously being a key component. And, you know, linking that with the question earlier about there's a variety of paths that an EMS practitioner may choose to take with her or his career, whether that's a public safety focus, whether that's a community health focus, whether that's a purely healthcare focus. There are some paramedics who work exclusively in traditional healthcare settings like emergency departments, for example. So I think we're seeing that evolve. That's part of the innovation journey. And when you reconcile that professional development with the types of approaches where you can unify team-based strategies, look at metrics that are important to all payers, it becomes a lot easier to standardize those conversations in multiple markets, multiple geographies, multiple states.
Great. Thanks, Dr. Beck. We've got a few questions revolving around education. We have Joseph's, the length of educational program seems much longer to me than necessary if you simply training up experienced paramedics to recognize the worsening stages of recognized disease entities compared to the patient's baseline. Who would like to field that?
I'm happy to start. This is Eric. You know, I think that there's a valid point, and that is that depending upon what type of clinical intervention, what type of community or navigation-related activity you're going to provide, the competencies, the training, the safety layer required to deliver that effectively, you know, may vary. And you know, standard curricula with well-established practitioners, well-established practice profiles can potentially kind of cobble the right needs and education for that particular practitioner. When you look at the history of new professions or disciplines, oftentimes the global needs from an education standpoint for that group are not totally defined on the front end. And I think what we're seeing is sort of an evolution. There are a number of curricula out there that have a number of excellent fits in terms of what activity is being provided. But there are other things that are being provided every day in traditional EMS systems that would fall into a mobile integrated healthcare intervention that don't necessarily require a formal credential or program. So I think we're going to continue to see a spectrum there. I think there's room for different flavors, different approaches. But to Matt's point, you know, we really do need to have some unifying overarching strategies, particularly when we're embarking in truly new practice territory, or when we're involved in activity that kind of moves beyond a traditional EMS competency arena. At the Evolution Health journey, we actually put all of our practitioners, not just our EMS clinicians, but advanced practice nurses, pharmacists, physicians, social workers through similar core training, and believe that there's enough competency required that's new for all of those folks in terms of the new delivery strategy. You know, not all members of the healthcare system have had equal exposure to EMS systems. EMS clinicians knows how to how to partner with them and collaborate, and vice versa. EMS may be less familiar with certain members of the team, and lots of ways to solve for that. And I suspect we're going to continue to look at new ways. But Matt's point around common denominators, standard approaches, being able to measure and validate competency associated with MIH learners is going to be critical.
Thanks, Dr. Beck. There's a question from Ellen, similar vein, I think. It's asked about using the word assessment by paramedics or we use the word assessment by paramedics to identify patient complaints as an element of appropriate decision making. Traditionally, assessment is a skill designated to nursing and physicians. Do the medics report patient complaints and findings to higher professionals such as physicians and nurses to reach a decision to divert to a care alternative instead of an acute care hospital? And I think I'll start off with just a brief overview that community paramedicine is an advanced assessment, but it is not a standalone service in any way, shape, or form. It is tightly integrated into a care model. It has to have that physician support, has to have nursing, mid-level, and everybody working together. And it's really an extension of that patient's care providers. So in the assessment or in the model of, say, a patient that's been sent home who has CHF, well, if that cardiologist isn't willing to be part of the care plan and be willing to take the call when the paramedics are noticing a change in weight, fluid retention, whatever, then the system isn't effective. And so what we have to look at here is that it's really an extension of that patient's primary care that the paramedic is bringing out. It is not the paramedic's role to be trying to make independent decisions on 100% of these cases. So that would be my 2 cents. Matt, from your experience, what would you add?
Yeah, it definitely requires primary care or specialty care intervention. Any EMS provider, and let's face it, we assess patients every day. Dr. Beck, the medical director, or medical directors are on the phone, or paramedics. You look at a patient, you use all of your diagnostic skills to make an assessment of what you think is going on with that patient, and then you formulate a treatment plan. Now, normally that treatment plan is based on protocol. In many cases, there are protocols for these programs, but the protocols in almost all the programs that are successful out there are collaborating the care plan with that patient with the patient's patient-centered medical home, because we can't do this alone. We can't adopt these patients and be able to deliver the integration that we need to improve their outcomes and to meet the triple aim. So in our program, I know in McKinney's program, I know in almost all of Eric's programs, any of the successful programs, we are just the conduit of information back to the decision maker, which is going to be the primary care physician, the hospice medical director, whoever it is that we're helping to integrate with and interface with, so that our assessments are going to be combined with several other types of assessments that are being done on the patient to help formulate, implement, and carry through a care plan for that patient to help improve their outcome.
Thanks, Matt. I'd like to add one more question I think we can squeeze in before our end of our session here, and that's from Nancy. And she asks if does EMTALA play any role in pre-hospital situations? And certainly in traditional EMS, EMTALA absolutely. We've talked about this a number of times over the years in taking patients to the most appropriate hospital. It's okay to pass one hospital if you're taking the patient to a trauma center based on activation criteria. Same would apply for stroke and STEMI. Is there other thoughts from our care providers out there? Dr. Beck or Matt or Chief Hockett, as far as EMTALA, have you run any concerns?
I'm going to ask if Dr. Beck is on the ACEP board.
So yeah, so I'm happy to just make a couple of overarching remarks. So, you know, as an emergency physician, as an EMS physician, there are lots of examples of EMTALA being brought to bear as it relates to EMS operations, out of hospital, pre-hospital triage, which may or may not be the same thing. each state has a slightly different set of laws, regulations, and rules. And as was described, there's some overarching tenets that are probably truths by and large. EMTALA was never, sort of designed to necessarily apply to specific and all future state innovative models. Having said that, there can be some challenges, particularly in some states where alternative destination or disposition done independently or done in a way that is prohibited or restricted by the EMS system may create some interesting challenge. There is a dialogue amongst some in terms of what is the burden. Hospital-based EMS systems as opposed to EMS systems that are disaffiliated or relatively unconnected from a structural standpoint with hospitals is also an interesting dimension of that consideration. I think that there's some historical precedents in terms of how EMTALA has been applied to hospital-based EMS agencies, but not necessarily more broadly. This will be part of the next chapter in the EMS innovation journey. And I think there are ways to solve for that. We're seeing interesting examples of telemedicine, of linkage, online medical control, a variety of strategies. But certainly it is a consideration. The scope and the specifics vary based upon a program, its clinical interventions, and the system design and regulatory environment that it operates within.
Great. Thank you, Dr. Beck. And I see we're at our limit, and so I would like to respect everyone's time and thank our presenters for doing an excellent job. We will be sharing the slides. You'll get a link as an attendee to that, so you are willing and able to share this out with other peers that may not have been able to make it today. Juliana, anything else before we go?
Yes, I'd just like to say that I will be sending out an email with an evaluation. We would appreciate if you would share that with any people who attended the webinar who were not, did not register. We would really appreciate that. And the presentation will be posted to the Abaris Group's YouTube channel, and I'll provide you with information about that too in that same email. Thank you all very much for your participation. We look forward to seeing you at another The Abaris Group webinar soon. Have a good day, everyone. Bye-bye.